In this module, we're going to cover the medical assessment. So we've already gone over the forensic exam in the 4-part series. Now we're going to include the medical assessment on head to toe and how we incorporate both into the forensic examination. It's a simultaneous head to toe assessment during your exam. You're going to complete the medical portion and the forensic portion simultaneously. You're going to take the objective information, that's what you see, feel, hear, and smell, and your exam findings. You're going to combine that subjective with the objective information. Remember, the subjective is what you receive from the patient during the questionnaire and the forensic narrative. And the subjective and objective together will be a complete forensic examination. You're going to document all findings regardless of the situation. Your job as the forensic examiner is to make sure that you're documenting all findings. Some things that you want to avoid: you never want to write within normal limits or any type of assessment normal, because what's normal to one person may not be normal to the next. And I know that's contradictory to what we all learned in nursing school for what the normal limits were. However, when it comes to forensic assessments, you never want to state within normal limits. You want to document your objective findings of what you saw during the exam. Remember, forensic examinations are not a general medical assessment. Your responsibility is to document everything that you see as you see it. It's a systematic assessment for each body region. It starts as a cephalocaudal exam, so you're going to start head to toe and move down the body. And I can say that most forensic examiners develop their own method of things, and that's completely normal to do. I don't think that two examiners do the same type of assessment. One may start with an alternative light source before they begin. The next may use 2 or 3 different assessment techniques and then incorporate the ALS. You'll quickly learn within the few examinations, the first few that you do, you'll really start to develop your own practice and what works best for you. You want to begin with an initial presentation. How is the patient appearing to you? What's the general appearance? The clothing, the demeanor, orientation. Are they alert and oriented? What's their emotional status when you walk into the room? All of that should be documented. Also, who is with the patient at the bedside? You want to make sure that there's a general safety assessment done, because as I mentioned before, it's possible that a patient that is a victim of human trafficking could have the trafficker at the bedside. So you want to do a careful assessment of who is with that patient. Also, if they're medically stable for the exam. You're going to use your subjective information, which is the questionnaire, the narrative, and all of the information that you've gathered from the patient up to this point. That's going to be your guide for your objective assessment. You're going to try to correlate that information. You want to include pertinent positives and pertinent negatives. And what I mean by pertinent negatives, I'll give you a scenario. There was a patient that stated that she was held for 2 to 3 days bound, and she stated that her wrists were bound with rope. And so I expected to find ligature marks or certain types of burn abrasions, and there was nothing. So I wanted to make sure that I documented I saw nothing from that, because the subjective information that I received from the patient did not match what I found on the findings. So that would be something that if you feel that that's a pertinent negative, you can document that, even, or take a photo of it, even if there's nothing there. If it's a pertinent negative where you're expecting something but there was nothing, then that's absolutely something that you should document and include in your chart. It's your responsibility to see if it correlates or not. And remember, sometimes things won't correlate, and that's not your just job to make it correlate. Your job is to make sure that if it does correlate, the findings are present. But again, they may be absent. Consider normal variance on why a finding may be absent. We talked in detail about females and the average age of the assault. So if you take a 24-year-old female, her last menstrual period was 16 days ago, and let's say it was an acquaintance rape during their second date, and there was potential consensual kissing or any other type of interaction. However, the act of sex was not consensual. That patient is already going to have stimulation to the Bartholin and Skene's glands, and there is possibly going to be lack of injury there, as we discussed pretty heavily. So that would be a pertinent negative. However, again, just because something's absent, you need to consider why it's absent, like those normal variants on going back to the anatomy and physiology of the body. The assessment techniques that you'll use, inspection and palpation. We really don't use too much auscultation and percussion because remember, this is a focused examination. However, you will be using the ambient light in the room, tangential light, and also the alternative light source. And I can say that tangential light is usually something that's overlooked commonly in forensic nursing. However, it is an extremely valuable tool to assess contours and if there's any swelling. Not just, it's commonly seen in nursing to assess JVD. However, remember, a pen light goes a long way. Also, the use of ALS. Now, sometimes you'll use your ALS throughout the exam several times, and it's best to try to consolidate the use so you're not turning on and off the lights 10 to 15 times during the exam. What I try to do is try to average it about 3 times. Upon initial arrival, I will look at the patient with the lights off and with the ALS on, and the patient's clothing is on, and I look at the patient front and back with the clothing because that's something that we want to make sure to assess. And this is mainly for patients that wear the clothing that they were assaulted in to the hospital. I normally don't take this step if it's something that if the patient was assaulted 2 days ago and they're not wearing the same clothing. However, I always use it during the anogenital exam. I want to see if there's any type of fluid coming out of the vaginal vault or anal cavity that may fluoresce or contrast. Also looking for types of bruises that are those deeper bruises that you'll see with the ALS. And I also look at it on conclusion of the exam. It's one of the last things that I do. I inspect the entire front and back of the body, making sure that you're looking for areas. You pull the patient's hair up if they have longer hair. Make sure you're examining the neck for possible ligature marks or fingertip bruising. And it's a really good, useful tool if the patient does present a few days after the exam, because it's had adequate time for blood to escape from the capillary beds that they're in. If there is an injury that's already there and the blood is starting to migrate, and the bruise that wasn't evident 2 days ago may now be, and that may be amplified with the use of the ALS. So we're summarizing the inspection. When you do the inspection, ambient light, which is the direct overhead lighting in the room, and you can always use your resources. If you want a gooseneck light, you can absolutely request one. Most emergency rooms have them. You can also use the other light sources in the room, otoscopes. I use those quite a bit. Or you can bring your own pen light. And if you don't have a pen light on you, an otoscope light can work really well for tangential light. But make sure that you're dimming the lights in the room when you do that. Starting off with the HEENT, it's going to be a critical assessment that's performed with possible strangulation history from the subjective information from the patient. So you will perform the strangulation assessment, and it's a form that's located in the examination chart, and it really walks you through the entire assessment criteria for strangulation. It gives you those key pointers and assessment locations to look for. Moving to the head and the scalp, you'll want to inspect the scalp with ambient room light. You're going to be checking for missing hair segments, any scalp injuries, lacerations, petechiae. If a patient's strangled, they're very common location to find petechiae on the scalp. Also, membrane disruptions. If the patient gives you a subjective history of hair pulling, then you're probably going to look and make sure that there's no missing hair fragments. Also, inspect with the ALS. You can use contrast and fluorescence. And if you do see something that's in the hair that you want to take, if the hair does have positive findings, you can always use sterile scissors, and you can get that from a suture kit or request it from the ER, and cut out a piece of the hair if the patient consents to that. Or you can obtain a dry stain directly from the hair. You definitely want to palpate the entire scalp. You're looking for any swelling, any tenderness, pain, crepitus, deformity of any kind, and you'll note that accordingly. Here's some samples of some things that you might see. Also, make sure that you're looking for battle sign. That's an indication of a basal skull fracture. You would make sure to notify the physician immediately. Do not continue the exam until that's assessed. If you see significant bruising behind the ear, at the nape of the neck, at the hairline when you're doing your scalp assessment, you want to stop and notify the physician immediately, because that patient may need to be stabilized medically before you can proceed with the exam. Moving to the ears, you'll inspect the ears with ambient room light, and you're looking for injury, swelling, deformity, or petechiae. Also consider piercings if they're intact or if they're missing. If the patient was wearing earrings during the assault and there's none, or there's one missing or both missing, then it's important to notify the detective on the detective notes, or let them know as soon as you can. It may be an important component for them to assess the scene, so it may be left at the assault location, and that can help correlate the patient's statement with the events of the assault. And obviously, if there's any clear fluid coming out of the ear canals, you want to notify the physician ASAP, because there is a possibility that it could be CSF, especially if there was a subjective information about a head injury, or even potential strangulation. Make sure that you're inspecting it with the ALS. It's great to see contrast. Really not much will fluoresce in the ear canal. However, the contrast will be there. There could be scant blood in the ear canal, or there could be petechiae. And remember, where there's blood, it's normally going to contrast, especially if that blood is near the surface of the skin. And so here's an example of petechiae in the ears, in the ear canal. This is usually, it can be inside the ear canal, or it can be outside the lobes with strangulation. They could also complain of ringing in the ears. You may find fingernail impressions. Again, so make sure that you're looking for those signs. When you're assessing the eyes, you want to do inspection. You want to make sure to focus on the eyelids, the sclera, the pupils. Are they equal and reactive to light? Make sure that you're looking for any conjunctival hemorrhages. Also, again, piercings. An eyebrow piercing is a very common thing. So is there, number one, any increased injury, or number two, is there any type of DNA transfer from the patient to the perpetrator? Also, is it missing? So that could be just like the earring. If it's missing, where is it? So you want to let the detective know it could be at the location of the assault. You want to make sure to pull the eyelids down and take a peek at the inside and the conjunctiva. That's a very common place for petechiae to be, as well as the outside of the eyelids and the upper eyelids. And also visual acuity, if applicable. And so you don't necessarily have to perform a visual acuity exam. However, if the patient's stable and they report any vision changes, then you may suggest that to the physician when you're done with the exam. Here's some examples of conjunctival hemorrhages, and also there's a really good example of the petechial hemorrhages on the upper eyelid. You want to make sure to palpate, looking for on the lids, any orbits or temporal, anything that you feel that has swelling, pain, tenderness, nodules, that you can help correlate with the patient's subjective statement. Make sure that you're looking for any discharge from the nose, any color, consistency, amount. Really think DNA here. Nothing is too small. Look for the turbinates, look if there's any swelling, injuries, lesions, deformity. And also palpate it. If is there any tenderness or pain or swelling in the integrity of the nasal passages? And this is another one as well that a lot of people try not to, they really want to think that it's more of a medical and not forensic. However, it's still a finding. Some things such as the allergic shiners or allergic salutes. You're documenting everything you see as you see it. So still document it. You do not have to differentiate what you're seeing. You don't have to differentiate, is an allergic shiner, or is this from the patient crying? Is this an injury? You have to document it. We're just showing you an example here. But it would be a good idea if you see something like this and there's no history of facial injury and there's no, the patient hasn't been crying, then you may want to talk to the patient about allergies. And this is a great example. No finding is too small. We have a history of a successful prosecution from a fantastic job that PD did for their investigation. The patient had a very severe allergy to dogs, and the perpetrator had 4 dogs. And so the patient developed significant rhinitis. She was sneezing during the assault, and she had allergic shiners, the allergic salute. That was classic with long-term allergies and long-standing allergies. And the patient's DNA was retrieved from the assailant in 6 different locations because of that rhinitis and the sneezing. So really think DNA when it comes to something like this. No finding is too small on any body area. When it comes to inspecting the mouth, you want to make sure to use a pen light or that otoscope light. You're not going to be able to really see the inside the oral cavity with just the ambient light in the room. You want to really assess the area really well. You want to make sure you're looking at the frenulum, the hard and soft palate, the lips. Are there any teeth missing, hardware missing, any piercings of the tongue? We talked about that extensively in piercings. Also look for any petechiae inside the mouth, on the palate, and swollen tongue. That is a classic sign of strangulation. And you could also, during this step, obtain your oral swabs during that part of the assessment. And you can also use your objective history to obtain possible circumoral dry stains if reported of any kissing, licking, biting to any area, not just the mouth, but to any area. And this is a common location, circumoral to the neck, to the ears. That's a very common location for examiners to go to for dry stains. It's a pretty repetitive pattern that there's subjective information to do so. This is an example of some findings you may see with forced oral penetration and strangulation. Forced oral penetration, you'll see these injuries to the frenulum, the palate, the gums, the teeth, and also with strangulation, you'll see injuries to the soft palate and hard palate. Make sure that you're retracting the lips to assess really well the upper and the lower. Also, I want to go back to note, do not forget what I mentioned earlier in tattoos. When you're assessing and retracting the lips to assess it, don't forget that it is a common location for traffickers to actually tattoo lower lips with the name of the person that's their trafficker or their pimp. It's a very common location, so be on the lookout for that, and you should have a higher index of suspicion if you see that. With the head and the neck assessment, make sure again that you're using ambient light and tangential light. If there's any type of strangulation, it's very common to see neck swelling that you normally wouldn't see with ambient light. Looking for petechia, purpura, and remember the difference, going back to those nursing school days, difference with petechia, it's usually less than 0.5 centimeters. Purpura is usually anything above 0.5. So purpura, think of it as the larger petechiae. Also making sure that the trachea is midline. Is there any JVD distension, especially if the patient has a cardiac history with any venous congestion. Making sure that you're looking really well for fingernail indentation. If it's an acute assault that happened within the past few hours, then you may very well see fingernail indentations, or you may see transient lesions where the fingernails were. Making sure that you're assessing for ligature marks, any difficulty breathing, and of course always use your ALS, because any type of strangulation, any report of it, anything you may not see, with the ambient light, then you might very well see it with the ALS. And it is very, very common to see fingertip bruising during strangulation. When you're assessing the head and neck, you also want to assess for voice changes. Are they having trouble speaking or trouble swallowing? Are they constantly clearing their throat without a baseline history of postnasal drip or allergies? Any coughing, sore throat, any stridor, drooling, look for facial symmetry. If there's any facial asymmetry, then that would be something that you also, a red flag to go notify the physician immediately so they can be cleared medically. Also making sure that you're palpating, again, for any crepitus, deformity, trachea midline, tenderness, pain, swelling. This is an example of a strangulation. You can see there's a pretty significant pattern of injuries. And if there is any type of strangulation or kissing or licking, this is a common area that occurs, you want to get those dry stains. And remember, the dry stains, they're counterintuitive of what their name is. Remember, all dry stains, that just means that the stain is taken at a dry location. You have to wet the swab. So the ×3 rule, remember it's 3 drops of sterile water, and then you take 3 passes rolling that along. It's a great location for touch DNA. Also, I want to say that if there's any bruising that may resemble a hickey or some type of area that's had suction applied to it, those are tremendous DNA harborers. So I would really focus on swabbing that area really well, because you may be able to pick up DNA that's well past the time frame of what you would normally expect, even after a shower, even after several showers. This is an example. The photograph on the right is a picture of using the ALS or a contrast, and then you can see the faint fingertip injuries on the left, and some further injuries. When it comes to strangulation, you can actually see in the photograph there's fingertip contusions, and we're going to go into that a lot more with forensic injuries. However, if you notice here, you'll have multiple different injuries. Anytime you see fingertip contusions or bruises, you want to make sure to see anytime there's multiple, look for the contralateral side, because that's usually where the thumb is going to be. So there's 2 here, and look here on the contralateral side, and that's pretty indicative anytime you think that there's a fingertip bruising, and we're going to go into that more. I have this handout for you. This is a great handout. I've kept it with me for a long time. It's just a quick guide that shows signs and symptoms of strangulation that goes through a review of system. So then I move on to the anterior, and again, you may develop in your practice that you want to go to extremities, or you may want to go to the posterior, and that's okay. There's no rhyme or reason what you have to do. This is what I do. So you'll develop your own system, whatever system works for you. The important thing is that you're consistent. Whatever system you develop on your assessment for your head to toe in your forensic exam, then you need to make sure that you stick with that. Don't deviate from it. When you find a system that you like, don't deviate. It makes sure that it assures consistency. So with the anterior, you'll of course inspection and palpation. You'll use the same light sources, looking for all the same things: injury, swelling, lesions, scars, and deformities. And you'll also palpate. That's a very important thing, because you're going to miss something that you normally wouldn't see. You're looking for pain, tenderness, deformity, swelling, crepitus. And of course the anterior, you want to make sure that anything that's there already, you're documenting everything. So if they've had a child before, they're probably most likely going to have STRAE or Eschar, and so that's okay. If it's an older injury that's not, is not related to the sexual assault, that's okay. Make a very general statement, and I have an example on the next slide. But if you don't document something as simple as that, then how can competency be proven that you accurately and thoroughly assess that patient? So everything everything is pertinent. If there's a C-section scar, you want to note it's there. You do not want to miss any finding whatsoever. An example, if you do see striae or stretch marks, and you should call everything by its medical term. An example that I do is multiple striae to anterior right lower quadrant, left lower quadrant, white in appearance, various measurements ranging 0.5 smallest to 6.5 largest. I do not measure if I know it's not related to the sexual assault, especially because the patient states it's not. I do make notations that it's there, however, and an example would be with the striae from pregnancy. Then if there's 30 to 50 of them on the abdomen, I'm not going to measure, I'm not going to mark and do a separate finding for everything. I'm going to lump that all together. And the best way to do that, especially if you're overwhelmed by an absolute ton of injuries in one location, you can measure the smallest to the largest. An example, you could even count it out. So let's say that there's 33 different striae locations on the abdomen. You can measure the smallest, which would be 0.5, or the largest, which would be whatever, and you can say that there's multiple in this quadrant, and then take a photo if you feel that it's pertinent. When it comes to striae or C-section scars, anything like that, I usually don't, as long as I notate it. And one great thing, if you remember going back to the paperwork that shows where you do your charting for debris, findings, there's a notation for the examiner comment, and there's a notation spot for the patient comment. It allows you to provide subjective and objective information on every single thing that you put down. And this is a great example. So my objective information, I'm writing it, and then the subjective information, the patient states, oh, those are from my pregnancy. You would put that in quotations because the patient stated that direct, spontaneous statement to you. And then, of course, repeat assessment for the posterior torso. Then I move on to the extremities. So I'm going to be looking again with the same ambient, tangential, and ALS. I'm looking for swelling, lesion scars, deformities. I'm going to do my palpation, tenderness, deformity, swelling, crepitus. One thing I do not do is assume, and this is a no-no in the forensic world. So you don't want to assume that a finding is from a specific thing. You don't know for sure, so you want to make sure that unless it was witnessed. An example would be if a patient has needle marks, or what obviously to us in the nursing world looks like track marks, and the patient has a history of drug use. However, you don't want to say track marks. You don't want to say needle mark or needle stick or needle injury. The best thing to do is document it objectively. Document it as you see it. So an example, let's say a blown IV site would be a 0.5 times 1.0 hematoma, blue in color, to the right antecubital fossa, with a central pinpoint puncture wound, tender on palpation, no acute bleeding noted. Just point blank to the point, and you're not making assumptions as to what it is. Also, don't forget range of motion to extremities. If the patient gives you a significant amount of information in the subjective story, and there is a potential injury for range of motion, then you want to make sure to establish that correlation, because pain is a finding. Also, you want to make sure on extremities, it's a very, very common location for ligature marks, fingertip bruising, patterned injuries, and the reason for that is because it's defense wounds for mechanical injuries. So it's a very common pattern, especially if you're thinking about the forearms. It's a very common location, and hands as well for defense wounds. And of course, when you're at this portion of the exam, then you can collect fingernail swabs during that assessment, looking for any touch DNA or any DNA sites from the subjective statement that you feel is pertinent to get a collection from. Here's an example of some bruises to the anterior. And you want to make sure that you're looking at anterior and posterior. You're documenting everything that you find. You're documenting as you go along. And then, of course, the genitalia assessment is what I normally do next, and that's covered in pretty extensive detail in other lectures, so I'm not going to go into detail here. However, one of the things I do want to note is make sure that you consider using the ALS prior to starting your genitalia exam. It's really important because, again, what goes up must come down. If there's semen in that vaginal vault, then it's going to absolutely come out. Also in the rectum, if there's semen or body fluids in the rectal area, in the rectal cavity, then it's going to probably come out. And you want to make sure that you're swabbing and assessing in the absolute right places to catch that DNA. So now we're going to move on to the forensic injury assessment, and this is going to give you a jumping off point to how we do baseline injury assessments when it comes to the forensic application. So one of the things I would like to caution you with is a description of wounds. It is a very common pitfall for examiners to fall into patterns of labeling everything the same. Absolutely do not do this. You want to make sure that you are using the appropriate nomenclature for what you are seeing. And a lot of this may be carelessness or unsure. I think one of the biggest things is they're not sure what they're seeing. So it's important to really focus on this material, study it, review it. And if you want further information or education, we're going to do that. We do that several times a year, but if you want specific information on a topic, let me know and I'd be happy to walk you through everything. So an example would be a laceration. A lot of people just use laceration for every break in the skin, and that is absolutely not true. We're going to go over those specific things. When it comes to injuries, you want to measure the size and the shape. You always measure in two different fields. The great tool that is one of my favorites is the L-shaped ruler. That way you can easily measure and identify the length times the width or length times the height. You want to describe the shape of the wound too in words. Is it linear, ovoid, crescent, V-shaped, S-shaped, or whatever shape pattern it may have? And you want to look at the color, you want to look at the characteristics, drainage, the amount. Is it bleeding, oozing, is it serous, is it sanguineous or serosanguineous? You want to describe everything you see, going back to those nursing school 101. And you want to assess and you want to document the location. Use correct anatomical landmarks, and you can use the clock method anywhere on the body. It's not just reserved for the genitalia. You can use it absolutely anywhere. An example of that is if the patient had a significant amount of, let's say, abrasions to the abdomen, then I may indicate in my charting where the 12 o'clock is. Because again, if you're looking at the genitalia, then normally the mons pubis or clitoral hood is the 12 o'clock region. As long as you identify where your region is, then you can use that clock method anywhere on the body. So you name something the 12 o'clock or you name something the 6 o'clock, then you can use that clock method anywhere on the body. And it's a very quick way for you to identify very easy where things are. Now we're going to go into type of injuries. This is a transient lesion. Transient lesion is the forensic term for a slap mark. It's a blunt impact force to the skin. There's really no break in skin integrity. It looks like slight swelling. Looks like a wheal appearance, if you remember the wheal appearance from nursing school. And it does dissipate and fade, usually within a few hours. And this is ecchymosis. It's capillary disruption under the skin, aka bruising. I like to see ecchymosis. Lack of swelling there. That's the important part that differentiates it from a hematoma. There's no blood collection under the skin. If it was a hematoma, it would be raised. A hematoma is capillary disruption under the skin, however, it does have swelling. So that blood escapes into the perivascular tissues. It's going to have that contour, that raised elevation, and this is a great use for your tangential lighting. You're going to have a larger collection of blood. It's going to be a fluctuant mass under the skin. And depending on how much blood is in the perivascular tissue, it could be soft on palpation, it could be a harder mass on palpation. This is an example of a hematoma, so it's going to have that blunt impact force to the skin, and then the extravasation into the tissues. This is migratory ecchymosis. Migratory ecchymosis is very common with crush injuries, especially an injury bone on bone, like tissue over bone. It's a very deep injury. So think about an example is in the picture. You can also think about a broken bone. You may not see that bruising right away. It may take several days for that blood to migrate through those tissues, and it usually migrates to dependent areas. So an example would be in this picture. So you can see it migrated towards the lower legs, and however, it's a pretty significant amount here. The blood will migrate to dependent areas. The next thing is called tramline ecchymosis, and this is a phenomenal method for you to really get to know, because you can help law enforcement identify what objects are used during the assault. The big thing with tram lines, if you look at the picture, there's a blunt impact injury, and it's usually with a rod or whip-like. It looks, basically it's coming down on the skin with such force that it's pushing or extravasation into the parallel flanks. So you have a central clearing because it has pushed all of that blood into the parallel sides where that object is. Really, really important to make sure that you get to know and recognize this. That way you can actually help law enforcement know what type of injury that is and help them identify what type of object was used. These are examples of tram lines. You can see here there's central clearing, and that's the big way to differentiate what it is there's central clearing or central sparing. And that goes back to that central sparing is caused by that significant impact coming down on the skin and pushing the blood, and making that extravasation into the tissues, into the peripheral tissues surrounding it. Here's another example of it. When it's coming down on the skin, it's pushing that into the tissues, and it leaves these parallel lines with that central sparing or central clearing in the middle. And sometimes you can even tell if it's a round object, it may actually have more smooth, less well-defined edges. If it's a rectangular object, you may have more clearly defined margins along that tramline appearance. This is fingertip patterned ecchymosis. Generally fingertip, and you need to pay attention close, because a lot of examiners, I see the pitfall is they'll see small bruises and call them fingertips. However, they really need to have a high index of suspicion based on what it is. Also, make sure that you're listening to the subjective information from the patient, such as he grabbed me or she grabbed me here in this location. What they are usually 1 to 2 centimeters in diameter. And one of the things that is really hallmark for fingertip bruising is there's usually 2 or 3, as I mentioned before earlier in this lecture about the strangulation. Usually there's 2 or 3 ipsilateral and 1 contralateral. And what I mean by that is there's 2 or 3 usually, and remember, not all of your fingers will grasp something with the same strength. So usually it's those 3 fingers, maybe 2, that will have the largest amount of bruising or capillary bed disruption under the skin. Then you want to look at the other side of the extremity, because you want to see if there's any contralateral bruising, because your thumb has a significant amount of pressure that it can exert, and it's very common to have that contralateral bruising. So that's the hallmark. You have there's 2 or 3 ipsilateral, 1 contralateral, and also you're looking for a slight arch. Remember, when you grab something, your fingers are not all the same size. So if you can see here, this has that classic arch, and you can barely see this 4th bruise here. So it's going to have that arch. So again, look for the arch, look for usually 2 or 3 in a row, and look for that contralateral location. This is another example. So you can see here, this is more of a round pattern. This has more bleeding under the tissue. And so what this is these have more pressure that was exerted than this injury here, because the more pressure you exert, the more capillary bed disruption you're going to cause. And this is an example of that contralateral thumb indentation. This is a friction burn. Now a friction burn, and we're going to go over, there's several different types of abrasions. So I really want you to pay attention to what types of abrasions there are to make sure that you're calling the appropriate thing an abrasion. And I see a lot of, when I'm doing audits, I see a lot of things called abrasions. However, there's so many different categories, and you really need to know what categories they are. So a friction burn is generally a superficial reddened area, but the key hallmark indicator that shows that it is a friction burn is there's no linear marks. And this will make more sense in just a few more slides. And it could penetrate the dermis, it may not. It really depends on the velocity of impact on the object to the skin, or from the body part to the object. But it's very indicative. An example would be clothing. If a patient states that their clothing was ripped off in a specific location or a manner, then this is a very common finding that you'll see as a friction burn. And remember, there's no linear markings. That's a really good way, hallmark way to say this is a friction burn, is there's no linear marking. Now the next type of abrasion is a graze. So there's a larger surface area than a scratch. There's friction of the skin over a rough surface. So it's sliding, scraping, grinding injuries. And the key thing is it's parallel lines. Now they're uneven. They may be different depths within the skin, but there's uneven parallel lines, and there's heaping with trails. And what I mean by heaping, we'll go into it in just a few minutes to show you, but there's also ruffling. So it's a heaping, ruffling, and that's important because it shows the force and the direction. So it shows the direction that the force was applied in on the skin. And this is a really good way to correlate a patient's statement about what they said. An example of this would be, he pushed me, you know, when you're getting your forensic narrative, this is why body mechanics are so crucial. Let's say the patient stated, I fell onto the ground and I fell on my arm. I fell on my elbow, and then let's say that the patient describes falling on her elbow and then maybe moving her arm up. So it's scraping from her elbow towards her hand. Okay, so you can see a force of direction, or you would expect a force of direction. And you can actually see that. Let's say she fell on gravel, or any type of friction burn that had severe grazes through it that does have linear lines. That was from a rough surface. If you look here, there's this is something coming into contact with the skin, and then the direction of travel is here. So it's going that way, and then you actually see if you got a magnifying glass on a graze, you could see the ruffling and the heaping of the skin. So there's a pretty significant amount. And if you notice here, the direction of travel is going from left to right, and there's an indentation and a notch. So it's a very clean edge, and then this is a very rough edge here. And this will make sense when we go to the next slide to show you an example. Now there are different types. There's a first, second, and third degree, depends on how much of the epidermis or subcutaneous is involved. So here's an example. If you look at this graze here, there's a pretty deep indentation here, and then there's linear lines. That's how you can really tell that it's a graze, but there's also multiple. So it's a larger surface area, and you see this deep indentation here, and then there's striated linear pattern, and one of the hallmark things with it is there's trailing as well. So if you go back to here, it's heaping with trails. You can see here there's scant trails. It doesn't necessarily have a clean edge. It's got trails. So the direction of force, it started here and went down. So it started, let's say an example of that would be, it started at 12 o'clock and it went to 7 o'clock was the direction of travel. This is another example here. You can see this clearly. And so it actually correlates with this because you have the cleaner line and then you have it going down with the trailing. This is a really good example. It's a grazed knee. So you have the fairly solid line of demarcation where it's a deeper injury. You see parallel lines running through the injury, and then you see trailing. It gets uneven. There's some deeper here, but then it lightens up. So this big line of that epithelial notch with that epithelial heaping and then the trailing shows the force, the direction of force began at 6 o'clock and went towards 12 o'clock or 12:30. And this is a scratch. It's the same thing as an abrasion, however, it's one single thing. You can have a pinpoint scratch, however, that is considered a technical scratch. So it's a linear abrasion. It has a deeper wound at the initial impact, just like a graze does, and it has the trailing or skipping at the end. It also shows the direction of force. The difference between a scratch and an abrasion is the abrasion is multiple lines that cover a bigger surface area, and a scratch is one single line. It could have 2 or 3 next to it. However, you can see the actual site of injury from start to finish is one single linear line. So here's another example. It started here, went to here. You see the skipping. That's a very classic sign of where the injury is actually trailing off. And this is a great example as well. This is another scratch. So you can see it's a deeper impact here. It's a deeper injury here. And then it goes up the skin and then it starts to fade. However, it starts to trail, and it's sometimes you'll see the classic skipping pattern. So it's got the deeper injury, it's linear, and then you see the lightening of it, and then you can see some of the skipping trailing. Now the next type of injury is a laceration. A lot of people call any cut in the skin a laceration. However, there is an absolute difference between an incision and a laceration. And remember, an incision, it's not just a surgical incision. It can also be an incision with a knife or an object. So the big classic ways to differentiate between a laceration and an incision, we're going to go over that in just a few minutes, or actually right now. So the laceration, it really does mimic an incision wound, but the way to tell the difference is because a laceration is shear force. It's usually tearing over skin. It's very common in bony prominences. If you've ever hit your ankle on something and tore it open, that's a classic laceration. It's got that shear force, that blunt impact trauma. The margins are slightly elevated. Here's a great example of that here. They're slightly elevated. They're going to gape open. It's going to have ragged edges. The margins may be bruised. You'll have vessels and tissue bridging. That's a very common, easy way. Some lacerations may be straighter, but they may also have tissue bridging, and this is an example of that. That tissue bridging. With a laceration, you don't normally see that because you have a clean incision deeper through the skin layer. Also, lacerations can be soiled with dirt, grit, fragments, or anything else from the crime scene. It's usually higher risk of infection as well. This is an incision, so you've got clean edges, there's clean penetration through the skin, there's no inversion of margins. You can see the margins here are very clean. It's usually also linear. It can be different shapes. However, if you compare this, which is that sheer, blunt, tearing force, to this, which is that clean incision line. Also, usually there's a lack of bruised or abraded edges. And it's very unlikely to see tissue or vessel bridging in incisions. Lacerations, they do have that tissue bridging. This is an example side by side. So these two are, this is an incision, this is an incision, this is a laceration. So you can see the meat layer here, you can see the subcutaneous layer, you can see the muscle underneath with subcutaneous layer. However, this here, you can see the tissue bridging, it's got the indurated edges, it's got the bruising around it, it's also got the significant arc here in the wound. Also stab wounds, so there's different types of stab wounds. You can have fishtail injury, which is a dull side entering. That's a classic, let's say your kitchen knives, if there was an injury, it's going to have a fishtail because one side is going to cut. You're going to have that point, which is penetrating the skin. You're going to have one side that's going to cut, and then the dull side is not going to cut. You can also have the elliptical, which is a double, let's say a regular knife that you would think of. That's going to have a double-edged knife that's going to be sharp on both sides. Then you can also have like the rounded or oval with the scissors edge. So you're going to have the penetrating injury, and then you'll have dull edges, and that usually also causes bruising. Any round oval that's with a blunt object that's not continually piercing the skin as it enters, it usually has a lot of bruising. You can have notched wounds as well. That's usually if it's withdrawn and then reinserted, or if it's twisting during penetration, you'll have the notched wounds. More than likely, the notched wounds, you can definitely tell tunneling is different. But the most common thing is usually it's withdrawn and then reinserted to create that notch. Here's an example of stab wounds, and the stab wounds that I talked about, let's go back to here. You can have the elliptical, which is the double-edged, and that's what this is. This is double-edged, nice elliptical. Next injury is bite wounds. Bite wounds are really, sometimes it takes an art to identify an actual bite injury. However, there really are some key characteristics that can help you identify and differentiate a bite wound from another type of wound. The thing that you'll see are dental arches. They may be oval, they may be round. This is a pretty nice, perfect little injury here. However, and trust me, they don't all look like this. But one of the big things with it is you'll have central sparing. And you may have like some scraping wounds that are going towards the central sparing, and that's from that teeth coming down on the skin and then letting go. Normally people that bite down during an assault, they don't necessarily open their jaw to let go right away. It's usually a biting, pulling, tearing force. So you're going to have scrape wounds going towards the center, usually from the upper and the lower. Also, is there individual teeth detail present? So do you see an individual tooth pattern? And here you can very clearly see individual teeth patterns. This was a very significant bite wound. Also, can you see any type of deformities? So is it characteristic? If you look closely here, you can see this, you can see there's a deformity in the teeth here. This is actually more curved in where these are more straight. And consider this, where there's a bite wound, it's not necessarily always possible that it was directly on the skin. They could bite through clothing. If they bite through clothing, then you're not going to see a lot of the characteristic dental impressions. You'll actually more likely see bruising. That may have the dental arch bruising. You may be able to see individual teeth bruising. However, you're usually not going to see the epithelial heaping, and we'll go in an example with the next slide with that. But some of the differentials that you should consider are heel marks. It's very common to get a bite mark mistaken for a heel mark, especially if only one dental arch is seen. You're not always going to see two arches on a bite wound. A great example of that is, let's say the patient had a bite wound. However, only half of the only one dental arch or half the mouth bit down directly on skin. Let's say there was clothing on this section, so there's only going to be really one significant dental arch that can easily be confused with a heel mark. So it's really important to get that quality subjective statement from the patient. Also, some other things that to consider that are differentials would be electrodes. Very common to have a bite wound on the chest that looks like a bite wound, but it's actually an electrode. Irritation from a patient having an adhesive reaction to an electrode that was placed on the chest or somewhere else in the body. And remember too that multiple bite wounds from the same assailant on the same patient, they may vary. So really pay attention to trying to tease out key characteristics and hallmark characteristics of every single bite wound that you see. They're not always going to look alike. One of the key things with bite wounds, it is a hotbed for DNA. They harbor a significant amount of DNA for a very long time, even with multiple showers or baths. So really, if you see a bite wound, you need to swab it. I usually take 2 or 3 dry stains per bite wound because I want to make sure that I try to get as much as I can. So again, let's go over the characteristics on the next slide. This is a very classic bite wound that's you're more likely to see than something like this. Let's pick out the key characteristics. So number 1, this is a fairly fresh wound. You're going to see possible transient lesions. And if you remember what transient lesions are, it looks like a slap mark. However, it's like that erythema, redness, and swelling that's in the skin immediately following an injury. And you can see the transient lesion that's following outside the dental arch here. And you have a slight arch. It's very minimal, but you do have a slight arch. And you can see here the transient lesion, it has a more defined arch down at the bottom. You also have epithelial heaping. Now remember, epithelial heaping is where something comes in contact with the skin and it starts to abrade the skin. So you do have from the teeth at the bottom this line of epithelial heaping. And so remember, just like a graze, epithelial heaping begins where the most impact, where the highest, most tension against the skin occurs. Then you can also see individual teeth pattern. They're hard to distinguish the individuals, but you do see separate indentations with demarcations in the skin. Another thing is you have a direction of scraping. So remember that central sparing. Now it's not completely spared, however, compared to the top arch and the bottom arch, you do have scant central sparing or central clearing in this wound. Another classic thing is if you look at the trailing, if you remember the grazes, you have epithelial heaping here. And then remember the grazes with the linear abrasions. This is a graze that was created with teeth. So you have the trailing and it goes towards the center. You can look here very carefully and there's it goes towards the center. So that's the teeth mark coming down and it's biting down with a pulling away, trying to pull out of the mouth, and it's creating those abrasions along the skin. Another common thing that you'll see is petechiae. Petechiae is that just from the sheer force, that disruption in the capillary beds underneath. It's very common to see petechiae with bite wound injuries, and that's a classic sign. And you can see that here with the epithelial heaping, which is where the initial point of contact was with the lower teeth or with the set of teeth here on that dental arch. And you have the petechiae that's not far away from it. So using these key hallmark characteristics, you can help differentiate a potential bite wound injury to another type, looking for those key characteristics. And I also included on the next 2 slides some classic nursing school information for things that you may see on the skin, just to make sure that you're using them. I do have this printout also that you can print out and keep with you, making sure that you're using this information correctly, making sure you're identifying it using the right nomenclature for what you see. Here would be skin lesions that you may see. Make sure you identify them correctly. And also, these are vascular lesions that you may see as well. Remember, there's a difference between petechiae and purpura and ecchymosis, capillary hemangioma, telangiectasia, a venous star. So keep this with you. That way you can refer to it. I've been doing this a very long time, and I still have these in my bag as well. And as always, if you have any questions, let me know.